Good morning, students. This is the last lecture this year. It is devoted to antibiotics. Antibiotics belong to antimicrobial agents. Antimicrobial agents are the agents, substances which destroy or slow down the growth of pathogenous microorganisms. Depending on the methods of usage, antimicrobials are divided by two groups. First group, these are disinfectants and antiseptics. They are used locally or externally. The drug used for the action upon the pathogenous microorganisms in the external environment, clothes, dishes, for example, instruments, tables, walls, and all the rest, are called disinfectants. Disinfectants are not used for skin or mucous membranes, but the agents used for the skin and mucous membranes locally of the human body are called antiseptics. So the first group, antiseptics and disinfectants. These drugs are not introduced inside the microorganism. And the second group, these are agents introduced exactly into microorganism with the purpose to kill pathogenous microorganisms, are called chemotherapeutic antimicrobial drugs. Chemotherapeutic antimicrobial drugs. Principally, usage of any drug is chemotherapy. Drug therapy is synonym to chemotherapy because any drug is substance, is chemical substance or several chemical substances used together. But we call it drug therapy or pharmacotherapy. When we say chemotherapy, chemotherapeutic drugs, we mean the agents with relatively high toxicity. So antimicrobials are principally highly toxic. That's why usage of antimicrobials, which introduced inside the microorganism, is called chemotherapy. We also call chemotherapy while using anti-cancer drugs. This is also chemotherapy because these drugs are also very toxic. But now we are discussing antimicrobials. So antimicrobial chemotherapeutic agents used to kill pathogenous microorganisms inside the patient's body. Full stop. So there are two groups. Used externally and used introducing into microorganism. Antiseptics and disinfectants include two basic groups: organic substances, inorganic substances. We will not discuss today in details. Organic substances among antiseptics and disinfectants include phenolics, phenol group, alcohols and aldehydes, stains, detergents, nitrofurans, and biguanides. These are the basic groups of organic antiseptics and disinfectants. And inorganic includes halogen-containing agents, basically iodine and chlorine containing. Second group, oxidizers or peroxygen compounds. Third group, heavy metals or salts of heavy metals. And fourth, acids and alkalis. This is classification of antiseptics and disinfectants. Classification of chemotherapeutic antimicrobials. We distinguish 4 basic groups of microorganisms: bacteria, viruses, protozoa, and fungi. And we distinguish corresponding groups of drugs: antibacterial agents, antiviral agents, antiprotozoal agents, and antifungal, effective against these classes of microorganisms. Antibiotics belong to antibacterials. The first group, antibacterials, we see include synthetic drugs and antibiotics. So synthetic drugs, these are drugs produced by chemists, synthesized by chemists, and there are no these substances in nature. But antibiotics, these are antibacterial agents introduced inside the patient's body, but having natural origin. Natural origin. First of all, classification of synthetic antibacterials. We also will not discuss in details because I want to talk to you about antibiotics exactly. But synthetic antibacterials include following chemical groups. First of all, bactericidal agents and bacteriostatic. Bactericidal means active, effective. They cause the death of microorganisms. Bacteriostatic cause delay of growth, deceleration of growth and of microorganisms. So bactericidal, synthetic antibacterials include quinolone and fluoroquinolone derivatives. Nowadays we use mostly fluoroquinolone. Second group, oxy and aminoquinoline derivatives. Next, quinoxaline derivatives. Next, nitroimidazole and triazole derivatives. And bacteriostatics include sulfonamides, nitrofurans, thiosemicarbazone derivatives, and oxazolidinones. Historically, the first group of chemotherapeutics was sulfonamides. But nowadays sulfonamides are used very rarely. The most widespread group among synthetics is fluoroquinolone derivatives. So these are synthetic antibacterials. And now antibiotics. These are antimicrobial drugs which are obtained from natural microorganisms, mostly mild fungi and bacteria. These microorganisms producing antibiotics use these substances for suppression of other microorganisms in process of competition for dwelling place. We distinguish antibiotics biosynthetic and semi-synthetic. Biosynthetic agents are obtained from microorganisms. We take these substances exactly from microorganisms, purify and use. Semi-synthetic antibiotics are products of chemical conversion of biosynthetic substances. So we produce biosynthetics and add certain chemical radicals. And these substances are called semi-synthetic antibiotics. So biosynthetics and semi-synthetics. Short history of discovery of antibiotics. The first information was published in 1870 by British doctor John Scott Burden Sanderson, who observed that culture fluid covered with mold did not produce bacteria. It was very interesting, but we didn't know why. And you see following discoveries by British, Russian, French, American, German scientists. But of greatest importance, of course, first real discovery of antibiotics is in 1928 by Alexander Fleming from Great Britain, who discovered enzyme lysozyme and the antibiotic substance penicillin. He was the first who produced penicillin from the fungus Penicillium notatum. But you see that 14 years passed until American scientist Florian Chain and Russian academician Yermolyeva produced these substances to use in patients. So the first real antibiotic was penicillin. After penicillin, after 1942, gramicidin, 1944, streptomycin, and so on. Nowadays, we have approximately more than 150 different antibiotics. First of all, very serious situation is developed because of resistance to antibacterial drugs. We need all time new and new agents because development of resistant strains of bacteria is a serious problem. Resistance can be natural or acquired defense mechanism against certain drugs. Bacterial resistance can result from several mechanisms. First of all, enzymatic destruction of the drug. So synthesis by bacteria of special enzymes. Second, bacteria can mutate and become non-sensitive to antibiotic. Alteration of drug penetration into bacteria is developed. Bacteria can develop efflux pump and expel the drug. Antibacterial resistance categorized according to the name of the drug and resistant bacterial strain. For example, MRSA, methicillin, its name of drug, resistant Staphylococcus aureus. So this Staphylococcus is not sensitive to methicillin. Methicillin resistant Staphylococcus aureus. Or VRSA, vancomycin resistant Staphylococcus aureus. Nowadays we understand that antibacterial drugs shouldn't be overused. This is one of the basic reasons of development of resistance to antibacterial agents. Comparatively, resistance to synthetics and antibiotics is different. Resistance is developed exactly to or against antibiotics and almost not developed against synthetic antibacterials. Classification of antibiotics, modern classification. We classify because of chemical structure, because derivatives of certain chemical structure, of course, have one and the same mechanism and are very close by pharmacological properties. But I'd like to unite again chemical structure with activity. I told you that we distinguish two types of antibacterial action: bactericidal and bacteriostatic. Bactericidal is more effective action. It's killing of pathogenous microorganisms. Bacteriostatic, this is delay, stop of development. So first of all, bactericidal include following chemical groups: drugs containing beta-lactam ring. There are 4 subgroups of beta-lactam antibiotics: penicillins, cephalosporins, carbapenems, and monobactams. So first, but there are 4 separate groups in beta-lactam antibiotics. Second chemical structure: drugs which contain amino sugars, aminoglycosides. Glycosides are agents containing both sugaric and non-sugaric parts in molecule, glycon and aglycon. Aminoglycosides. Cyclic polypeptides, polymyxins. This name we can explain because first these antibiotics were obtained from bacteria polymyxa. Following group: drugs which contain macrocyclic lactone ring, macrolides azalides, macrolides catolides. We distinguish macrolides, but macrolides without addition azalides, catolides belong to bacteriostatic agents. Bactericidal include macrolides azalides, macrolides catolides, but chemical structure of simple macrolides and these macrolides are very close. Next group: glycopeptides. And some agents are not classified because they are alone in this chemical group. Drugs with different chemical structure. These are chemical structures of some antibiotics. We see here beta-lactam antibiotics. Beta-lactam. This is beta-lactam ring. Beta-lactam ring. In penicillins, in cephalosporins, in monobactam because only one bactam, beta-lactam ring. But here we see additional 5-membered and here 6-membered cycle. And carbapenems also additional 5-membered heterocycle. But this is beta-lactam ring. That's why we unite these 4 very important groups in one, having beta-lactam ring. So penicillins, which are substitutes of 6-amino-penicillinic acid. This is acid. 6-amino-penicillinic acid. 1, 2, 3, 4, 5, 6. In 6th position, amino group, and after to this amino group, different radicals can be added in this position. Penicillins, cephalosporins, derivatives or substitutes of 7-aminocephalosporanic acid. 1, 2, 3, 4, 5, 6, 7 amino. And in this position, chemists can add different radicals. That is why we have a lot of agents belonging to cephalosporins. Monobactams only beta-lactam ring, and in this position we add radicals. And carbapenems in this position to sulfur atom we add different radicals. Continuation of classification. We have discussed with you several groups of bactericidal, and now bacteriostatics include following antibiotics: drugs which contain 4 condensed 6-sided heterocycles, 4 condensed tetracyclines. Drugs, I told you, which contain macrocyclic lecton ring, macrolides. They were the first in this chemical group. And nowadays we have macrolides, azelides and catolides, which activity is more. That is why they have bactericidal type of action. Dioxyaminophenylpropane derivatives. Dioxyaminophenylpropane derivatives, or international name chloramphenicol group. Lincosamides, enzymycins, or second name rifamycins, and also several drugs with other chemical structure, streptogramins, and so on. So this is classification. Another classification by the mechanism of action. We distinguish in antibiotics 4 basic mechanisms of action. First, inhibition of synthesis of the cell wall components. We know that bacteria have, besides cell membrane, additional cell wall, which is very important for bacterial cells. So, agents inhibiting synthesis of cell wall components are penicillins, cephalosporins, carbapenems, monobactams, glycopeptides. our cells of microorganisms, don't have the cell wall. That is why these antibiotics are least toxic for our organisms. Second mechanism, impairment of permeability of the cell membranes. So agents which impair permeability of cell membrane include polymyxins, aminoglycosides in high concentration. Third mechanism, agents inhibiting RNA synthesis, ribonucleic acid synthesis, rifamycins or ansamycins. And fourth mechanism, inhibition of protein synthesis in the ribosomes. Include the most of antibiotics: tetracyclines, chloramphenicol, macrolides, azalides, aminoglycosides. You see that in high concentration they impair permeability of cell membranes. In lower concentration also inhibit synthesis of proteins. This shows us that aminoglycosides principally also effective but toxic. And lincosamides. So this is classification by the mechanism of action. Now let us discuss about certain groups, special groups of antibiotics. The first group, beta-lactam antibiotics. I told you that they include penicillins, cephalosporins, monobactams, and carbapenems. And the first is penicillins. I told you that penicillins were the first in the world antibiotics. Discovered first, penicillins. Once again, chemical structure. This is 6-aminopenicillinic acid, In this site, different radicals are added. In this side, beta-lactam ring. Penicillinase act. This was the first mechanism of development of resistance. First, when we started to use penicillins, effect with the grand effect. Very good effect. But in 2-3 years, some microorganism or organisms started to produce mechanism of resistance. They started to produce special enzyme, penicillinase. And this enzyme cleaves molecules exactly in the site of beta-lactam ring. That is why common name of this enzyme is beta-lactamases. One of beta-lactamases is penicillinase. And examples of different antibiotics because of additional radical. Benzylpenicillin. If here there is this radical, benzylpenicillin. Phenoxymethyl penicillin. Amoxicillin. Dicloxacillin, this radical. Ticarcillin, azlocillin. So you see examples of chemical structure of certain penicillins. And now let us discuss. So first of all, we distinguish biosynthetic penicillins and semi-synthetic. Of course, historically, the first was biosynthetics, but mechanism of action in all penicillins is one and the same. Biosynthetic, semi-synthetic. And it is associated, I told you, with inhibition, ability to inhibit synthesis of the bacterial cell wall components. More precisely, protein urein. Penicillins are divided by biosynthetic and semi-synthetic. First, biosynthetic. Biosynthetic are drugs which are destroyed in acidic environment of the stomach. They are used only by parenteral way. Biosynthetic. Biosynthetic are benzyl penicillins. They are biosynthetic. All the rest are semi-synthetic. Exactly this chemical structure is produced by mold fungi. The first preparation was benzyl penicillin, kalium, potassium, and natrium, sodium. International name is chemical benzyl penicillin, but in USA they often use penicillin G. So benzyl penicillin is the same penicillin G, but international is benzyl penicillin. So benzyl penicillin preparations include short-acting, the first ones, benzyl penicillin, natrium and kalium. This preparation acts 3 to 4 hours. That is why it's necessary to inject these agents 6 to 8 times daily. They are injected or intramuscularly or intravenously. Of course, it's very unpleasant, 6 to 8 injections. That's why pharmaceutical chemists started to find agents with prolonged effect. And long-acting, these are benzyl penicillins, but with additions. Benzyl penicillin procaine is local anesthetic, but addition of procaine to benzyl penicillin prolongs effect duration. Benzathine, benzyl penicillin, Russian name is bicillin 1. We call in Russian bicillin 1, but I think in English bicillin 1. Besides bicillin 1, we have bicillin 3 and bicillin 5. But these are combinations. If bicillin 1 is mono preparation, benzyl penicillin benzathine, bicillin 3 is bicillin 1 plus benzyl penicillin kalium and plus benzyl penicillin procaine. So there are 3 components. And after bicillin 5 consists of 2 agents, benzathine, benzyl penicillin, and benzyl penicillin procaine. It is called bicillin 5. According to the dose, they act 3 to 7 days, and sometimes more in very high dose. For example, bicillin 5, 1.5 million international units. Sometimes we use once per month. once per month. But principally, they are not acid resistant and should be introduced in injections. Spectrum of action of biosynthetic penicillins. Spectrum. It includes gram-positive cocci, streptococci, staphylococci, nowadays those which don't produce penicillinase, pneumococci, and bacilli, Corynebacterium diphtheria, Bacillus anthracis, Clostridium perfringens, Clostridium tetani, Actinomyces, and some gram-negative cocci, Neisseria gonorrhea or gonococci, meningococci, and spirochetes, Treponema pallidum. When this antibiotic was alone, we were happy. But after we started to understand that in different situations, these antibiotics didn't help because spectrum of action is principally narrow. 1, 2, 3, 4, 5, 6, approximately 10 different bacteria. That is why it was very interesting to have antibiotic with wider spectrum of action. But first of all, it was necessary to produce antibiotics against staphylococci. First, staphylococci were killed by penicillins. But very fast, they started to produce penicillinase. That is why we couldn't use penicillins against staphylococci, so in staphylococcal infections. That is why scientists started to think about synthesis or addition to these molecules specific radicals for first activity against staphylococci, second for widening of spectrum of action, of course, and also for having the drugs which are acid resistant. It's also interesting to have oral forms of drugs, not only injections. And the first semi-synthetic penicillins, the first was phenoxymethyl penicillin. In USA, penicillin V. Phenoxymethyl penicillin. Look, this is benzyl biosynthetic and this is phenoxymethyl. Very small chemical difference, very small. But the agent is acid resistant. That is why phenoxymethyl penicillins was the first oral penicillin. Principle, all the rest is same to short-acting biosynthetic penicillins, short-action duration. We should use 6 times daily, but one more. This phenoxymethyl penicillin can act on a bacterium causing ulcer of stomach Helicobacter pylori also. Second subgroup of semisynthetics, penicillins resistant to staphylococcal penicillinase. Inhibiting penicillinase of staphylococci. That is why can destroy this microorganism. The first was nafcillin. It was first resistance penicillin resistant against staphylococcal penicillinase. Nowadays we don't use, but we use following drugs: oxacillin, cloxacillin, dicloxacillin, flucloxacillin. They are derivative of the same chemical structure. That's why we call isoxazolyl penicillins. So isoxazolyl penicillins means semi-synthetic but resistant to staphylococcal penicillinase. So spectrum of action almost the same. Almost the same. But additionally, they act on all staphylococci. That is why we started to use these agents for treatment of staphylococcal infections. Short break. The break is over. Let us continue our lecture. So, semisynthetic first subgroup, phenoxymethylpenicillin acid resistant. Second subgroup, penicillins resistant to staphylococcal penicillinase. These are isoxazolyl penicillins used for staphylococcal infection. Third group, drugs, agents having extended spectrum of action, but susceptible to penicillinase. Destroyed by penicillinase, but with extended spectrum of action. In this group, we distinguish three chemical subgroups. The first, aminopenicillins, ampicillin, amoxicillin, bacampicillin, penamecillin. Carboxypenicillins, ureidopenicillins. For aminopenicillins, spectrum of action includes gram-positive cocci, same, bacilli, also listeria and klebsiella. Additionally, listeria and klebsiella. And also intestinal group of bacteria. Carboxypenicillins include carbenicillin, carfacillin, carindacillin, ticarcillin. And ureidopenicillins include azlocillin, meslocillin, piperacillin. For these two groups, additional are Pseudomonas aeruginosa, Vibrio cholera, Enterobacter, Proteus vulgaris, and anaerobic bacteria. So spectrum of action is of course widened, is extended. And aminopenicillins, besides, have two forms, and for injections and for tablets. Some of them, for example, ampicillin, amoxicillin, can be used and in injections and orally also. These are semisynthetic with wide spectrum of action. But it was interesting to unite a wide spectrum of action with activity against staphylococci. Fourth group, drugs which have extended spectrum of action and are penicillinase resistant. But we failed synthesizing this agent. There is no mono preparation for this. That is why we started to use combinations. First of all, combination of semisynthetics with wide spectrum of action with one of isoxazolyl, so resistant to penicillinase. Ampicillin plus oxacillin. Combination is called ampiox. So this is antibiotic from the group of penicillins, which can be used and orally and in injections, which has wide spectrum of action, including all staphylococci. And second combination. In this combination, first is semisynthetic penicillin, and second, one of clavams. The group of clavams first used as separate antibiotics, but activity is not high. That's why we stopped to use as separate, but started to use as addition because of ability to inhibit penicillinase. Clavams include clavulanic acid, sulbactam, and tazobactam. And these combinations are called protected penicillins. So penicillins protected from cleavage by penicillinase. Examples: saltamicillin, it is ampicillin plus sulbactam, one of clavams. Amoxicillin clavulanate, we see combination amoxicillin plus clavulanic acid is used nowadays. Timentin, ticarcellin plus clavulanic acid. Ticarcellin belong to carboxypenicillins. And tazocin is piperacillin, one of ureidopenicillins, plus tazobactam, one of clavams. These are penicillins having wide spectrum of action and effective against staphylococci. Aminopenicillins are used for treatment of infections of urinary tract, biliary tract, respiratory ways, GIT infections, and in purulent surgical infections caused by gram-negative microorganisms. But carboxypenicillins and ureidopenicillins are additionally effective against Pseudomonas aeruginosa, Proteus, Escherichia coli, and mixed infections. Principally, all penicillins are not very toxic, not so toxic. But penicillins can cause allergic reactions. This is typical for penicillins. Even development of anaphylactic shock. In oral introduction can cause glossitis and stomatitis. And in use of extended spectrum drugs, superinfection in the form of candidiasis. These are possible side effects of penicillins. Cephalosporins. Cephalosporins also was produced as antibiotics with wider spectrum of action and which are not destroyed by penicillinase. Mechanism of action of cephalosporins is associated with inhibition of synthesis of bacterial cell wall components. They are not destroyed by penicillinase, but may be inactivated by other beta-lactamase, which is called cephalosporinase. Cephalosporinases can be synthesized by some gram-negative bacteria. Type of action: bactericidal. Action spectrum extended, wide, but depends on generation. Nowadays we distinguish already 5 generations of cephalosporins. Toxicity is relatively low. Can be allergic reactions cross-linked to penicillins. Some of agent, but especially of the first generation, have nephrotoxicity, can cause leukopenia, local irritation in injection, and superinfection. These are possible side effects. The first agents we call now first generation cephalosporins include agents used for parenteral introduction, cephalotin, cefepime, cefazolin, and for enteral oral introduction, cefadroxil, cefalexin, cefradin. Spectrum: gram-positive cocci, including staphylococci, gram-negative Escherichia coli, Salmonella, Shigella, Klebsiella, pneumonia, Proteus mirabilis, Pseudomonas, indole-positive Proteus, Enterobacter, Serratia, Citrobacter, Bacteroides fragilis, Listeria, Haemophilus, Neisseria gonorrhea. So this spectrum is close to spectrum of aminopenicillins. We used first generation agents for treatment of staphylococcal infections, polymicrobial infections in soft tissues, urinary tract infections, and prophylactics of surgical infections. Nowadays, first generation is not used. That is why you may read this information, but I will not discuss second generation. For parenteral introduction, we can use nowadays cefamandole, cefuroxime, cefoxitin, cefonicid, cefprozil, cefmetazole, cefotetan, ceforanide. And for oral introduction, cefaclor, loracarbev, cefprozil. Second generation, active against microorganisms which are sensitive to first generation. And additionally, so spectrum action includes all bacteria's characteristic for first generation, but additionally Enterobacter and indole-positive Proteus. Some drugs effective against Bacteroides fragilis and some strains of Serratia. Second generation drugs are less active against gram-positive bacteria than the first generation drugs. Like first generation agents, they are not active against Enterococci, Pseudomonas aeruginosa, and Listeria. No first, neither second generation can be used for these infections. So, second generation mostly effective against gram-negative, but also for gram-positive, but more for gram-negative. Third generation. The major features of these drugs are their expanded gram-negative coverage and ability of some to cross the hematoencephalic barrier that allows the use for treatment of meningitis. In addition, they are active against Citrobacter, Serratia, Enterobacter, cephalosporinase producing strains of Haemophilus and Neisseria, some of them not destroyed by cephalosporinase. Ceftazidime, cefoperazone, cefotaxime also have high activity against Pseudomonas aeruginosa. Third generation cephalosporins almost not active against positive cocci. Almost not active, but highly active, effective against gram-negative, you see. And agents mostly used for parenteral use: cefotaxime, ceftriaxone, ceftizoxime, cefoperazone, ceftazidime, moxalactam, cefadizime, cefpyramide. Almost all of them are used nowadays. And for internal use for oral: cefixime, cefpodoxime, ceftibuten, cefatamet. So third generation drugs are popular nowadays. But nowadays we have also fourth and fifth generation. So fourth generation, nowadays we have only for parenteral introduction: cefepime, cefpyrone, cefclidine, cefluprenam, cefozopran, cefquinom. Fourth generation preparations similar to the third generation cephalosporins, but are more resistant to hydrolysis by cephalosporinase and more effective against Enterobacter, Pseudomonas aeruginosa, and gram-negative positive cocci also. If third generation almost not effective against positive, fourth generation again, like second generation, act on gram-negative. A lot of different bacteria gram-negative, but also gram-positive cocci. They are able to penetrate through the hematoencephalic barrier, and they are universal antibiotics for start chemotherapy. Cephalosporins of the fifth generation, we are starting only to use these drugs. They include ceftobiprole, ceftaroline, and ceftolozane. They differ by a broader spectrum of activity aimed at, in contrast to previous generation, even for treatment methicillin-resistant Staphylococcus aureus, MRSA. Combined drugs: cephalosporins, ready-made drugs of cephalosporins with addition agent. Combination with beta inhibitors for beta-lactamases: cefoperazone, third generation, plus sulbactam. This is one of clavams. Ceftazidime, also third generation, plus clavulanic acid, also is clavam. Clavams inhibit and penicillinase and cephalosporinases. And one more combination: ceftazidime, third generation, plus one of fluoroquinolones. This combination, ceftazidime plus fluoroxacin, is also very effective. Side effects: allergic reactions, which can be crossed with penicillins. For first generation, nephrotoxic action, hyperprothrombinemia and bleeding disorders. For second generation, superinfection, and in the use of cephalosporins, alcohol and alcohol-containing medications must be avoided. Because these drugs inhibit metabolism of alcohol, causing accumulation of toxic acetaldehyde in the organism. But principally in treatment with any drugs, alcoholic drinks are contraindicated. Carbapenems. I showed you the chemical structure. carbapenems include imipenem, thianam, which is combination of imipenem plus cylastatin, meropenem, bipenem, penipenem, carbapenem dithiocarbamate, doripenem, ertapenem. Mechanism of action is associated also with the inhibition of synthesis of bacterial cell wall components. Imipenem is very effective, but is inactivated by dehydropeptidase 1 in renal tubules. That is why imipenem is effective in different localization of infectious process, except for kidneys. So cylastatin is additional agent which inhibits this enzyme, dehydropeptidase. That is why this combination can be used for also treatment of renal infections. Imipenem can't be used, but thianam, imipenem plus cylastatin can be used. Type of action, bactericidal. Spectrum of action, gram positive. Corynebacterium diphtheria, staphylococci, streptococci, gram negative. Achromobacter, Acinetobacter, Aeromonas, Brucella. You see a lot of different microorganisms upon no penicillins, neither cephalosporin act. Effective against Neisseria, gonorrhea, Proteus, Pseudomonas, Salmonella, Serratia, Shigella, anaerobic microorganisms. Usage. These antibiotics used for treatment of polyresistant infections, pneumonia, nosocomial infections, urinary tract infections, infections of abdominal cavity, septicemia, surgical infections. Toxicity is relatively low. Among side effects are allergic reactions, nephrotoxicity, dyspeptic disorders, local irritation, superinfection, and coloring of urine red. While using these antibiotics, a patient can see red color urine. It's not a problem after end of treatment. This manifestation is over. Monobactams, also beta-lactam antibiotics, also with the same mechanism of action, inhibition of synthesis of bacterial cell wall components, include Aztreonam, Pyrasmanam, Tigemanam. These agents have bactericidal type of action, relatively resistant to beta-lactamases, but spectrum of action, unlike of cephalosporins and carbapenems, is narrow and includes gram-negative bacteria, meningococci, gonococci, Escherichia coli, Klebsiella, Morganella, Proteus, Pseudomonas, Salmonella, Serratia, Shigella, Yersinia, Bacteroides also gram-positive. Toxicity is relatively low. The drugs can cause allergic reactions, nephrotoxicity, hepatotoxicity, dyspeptic disorders, local irritation, superinfection, but not often. Usage for treatment of infections resistant to another drugs, nosocomial infections, urinary tract infections, infections of abdominal cavity, septicemia. Septicemia. These are chemical structures of aminoglycosides. Aminoglycosides. Sugar, you see, sugar, streptomycin, amikacin, sugar, sugar, and amino group, aminoglycosides. Aminoglycosides nowadays also include several generations preparations. The first generation, oldest, include streptomycin, monomycin, neomycin, kanamycin, paromomycin. They are almost not used. Second generation, gentamicin, tobramycin, cyclomycin, netilmycin. Among these drugs nowadays we use netilmycin. Third generation includes amikacin, and fourth generation arbacacin, isopamycin, dactymycin. Mechanism of action associated with irreversible inhibition of protein synthesis in the ribosomes of microorganisms. But I told you also in high doses they impair permeability of cell membrane. Type of action, bactericidal. Spectrum is wide. Gram-positive Staphylococci, Streptococci, Mycobacterium tuberculosis, Gram-negative Pastorella tularensis, Pastorella pestis, Pseudomonas aeruginosa, Proteus, Escherichia coli, Serratia, Enterobacter, and some other. Usage. Some of them are used for tuberculosis and other sensitive infections. Toxicity is high. Side effects include allergic reactions, affection of the vestibular and acoustic ramus of the eighth pair of the cranial nerves. That is why we should use calcium pantothenate to decrease this toxicity, neurotoxicity, nephrotoxicity, dyspeptic disorders, local irritation, superinfection, especially preparation of first and second generation. We use streptomycin for treatment of tuberculosis. That is why if we use this agent, of course, we should use calcium pantothenate. Amikacin and especially fourth generation are of least toxicity. Arbacacin, isopamycin, and dactymycin can be used even in small children. Polymyxin, cyclic polypeptides. Polymyxin. This is chemical structure of polymyxin B. Cyclic polypeptides or polymyxin includes polymyxin M sulfate, polymyxin B sulfate, colistin, and colistimatate. Mechanism of action is damage of microbial cell membrane, causing impairment of permeability. Type of action, bactericidal. Spectrum is narrow and includes gram-negative bacteria, Pseudomonas aeruginosa, Pastorella, Escherichia coli, Salmonella, Shigella, Haemophilus influenza, Brucella. That's why mostly used for treatment of intestinal and skin infections. Intestinal and skin infections, so locally. Toxicity is high. Can cause allergic reactions, nephrotoxicity and neurotoxicity characteristic. Dyspeptic disorders and superinfection can develop. Cyclic polypeptides. azelids, macrolides, and azelids and ketolids. Erythromycin, macrocyclic lactone ring, macrocytic lactone ring. That is why they are all macrolides. But this one is simple macrolide. Azithromycin is macrolide azelid, and erythromycin macrolide ketolid. Azelids and ketolids have bactericidal activity. That is why we discuss these macrolides azelids and macrolides ketolids. Mechanism of action for all macrolides is irreversible inhibition of protein synthesis in ribosomes of microorganisms. Type of action of these two subgroups: bactericidal. Azithromycin belongs to azelids. Spectrum of action is not so broad, but wider than penicillins. Gram-positive cocci and bacilli, like penicillins. Gram-negative cocci, Treponema pallidum, but also Haemophilus influenza, Moraxella cataralis, Bordetella pertussis, Legionella, Chlamydia, Mycoplasma, Ureaplasma. So wider, of course, than in penicillins, and some cephalosporins. And characteristic is the ability to penetrate into the cell. So they act for intracellular bacteria. And for ketolids, telithromycin, additionally to these bacteria, Streptococcus pneumoniae, Streptococcus pyogenes, Enterococci, Mycobacterium avium, Gonococci, Meningococci. We use these drugs for treatment of tonsillitis, bronchitis, pneumonia, gonorrhea, chlamydiasis. Toxicity is relatively low. Can be allergic reactions, dyspeptic disorders. Vancomycin belong to glycopeptides. Besides vancomycin, this group include teicoplanin and ristomycin. Mechanism of action associated with inhibition of synthesis of bacterial cell wall components. Type of action: bactericidal. Spectrum of action: gram-positive, Streptococci, Staphylococci, Corynebacterium, Clostridium. Usage for treatment of penicillin and cephalosporin-resistant infections, and for treatment of enterocolitis. Toxicity is high. Side effects: allergic reactions, nephrotoxicity, neurotoxicity, dyspeptic disorders. Phosphomycin. Mechanism of action associated with inhibition of a very early stage of synthesis of the bacterial cell wall. Also act upon cell wall, but not inhibit synthesis of urine. Type of action: bactericidal. Spectrum: some gram-positive, Streptococci, Staphylococci, and some gram-negative, Pseudomonas aeruginosa, Proteus mirabilis. Used for treatment of urinary tract infections. Toxicity is low. Side effects: allergic reaction, dyspeptic disorders, skin rashes. skin rashes. Bacitracin. Bacitracin. Mechanism of action: inhibition of synthesis of bacterial cell wall components. Type of action: bactericidal. Spectrum: gram-positive streptococci, staphylococci. Usage: mostly local, for treatment of skin and wound infections. Toxicity is high, that's why local use. Side effects: allergic reactions, nephrotoxicity. In local use, no nephrotoxicity. Tetracyclines: 1, 2, 3, 4. Condensed, 6-membered, 6-sided cycles. This is tetracycline, this is metacycline. So, tetracycline include biosynthetic agents and semi-synthetic. Biosynthetic include tetracycline itself, oxytetracycline, demeclocycline, and semi-synthetic doxycycline, metacycline, and minocycline. Glycylcyclines, they are close by the chemical structure, but this is separate group like tetracyclines, but glycylcyclines. Glycylcyclines include tigecycline. Mechanism of action of all of them, chemical structure is very close, associated with inhibition of protein synthesis in ribosomes or microorganisms, and also binding to calcium and magnesium ions with the formation of chelate complexes. That's why these agents can be accumulated in bones and teeth. Type of action: bacteriostatic. Spectrum of action is wide. Gram-positive staphylococci, streptococci, negative salmonella, shigella, pasteurella, vibrio cholera, anaerobes, rickettsia, chlamydia, mycoplasmas, amoebas. So antiprotozoal action also characteristic. Usage: for treatment of cholera, rickettsiosis, plague, brucellosis, tularemia. Toxicity is relatively high. Teratogenity, violation of skeleton and teeth development, allergic reactions, hepatotoxicity, dyspeptic disorders, local irritation, dysbacteriosis, candida mycosis, superinfection, accumulation in the bone tissue. Ordinary macrolides or simple macrolides. Mechanism of action is same to macrolides as it's a reversal inhibition of protein synthesis, but type of action bactericidal. Bacteriostatic. First generation include erythromycin or landomycin. First generation. Spectrum of action is not very wide, but a little wider than in penicillins, biosynthetic penicillins. But second generation, spectrum of action is wider. Additionally to these, second generation preparation and third generation act on Haemophilus influenzae, Moraxella catarrhalis, and clarithromycin, additionally on Helicobacter pylori. Second generation include spiromycin, roxythromycin, midekamycin, josomycin, clarithromycin, dierythromycin, chitazomycin. And third generation, fluoritromycin, roquitamycin, myocamycin. Usage: used as alternative antibiotics for treatment of infections with resistance to penicillins. Toxicity is relatively low. Allergic reactions, dyspeptic disorders. Chloramphenicol. Chloramphenicol. Or derivative of dioxyaminophenylpropane. 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 Phenylpropane. So chloramphenicals include levomycetin, levomycetin stearate, levomycetin natrium succinate, and synttomycin. Mechanism of action: irreversible inhibition of protein synthesis in the ribosomes of microorganisms. Type of action: bacteriostatic. Spectrum of action: gram-positive cocci, gram-negative Escherichia coli, Salmonella, Shigella, intestinal group. Also Rickettsia, Chlamydia, Brucella, Pastorella tularensis, Pastorella pestis. Usage: as alternative antibiotics for treatment of abdominal typhoid, rickettsiosis, salmonellosis. Toxicity is high. Side effects: allergic reaction, dyspeptic disorders, hematotoxicity, so-called gray baby syndrome, dysbacteriosis, candidamycosis, superinfection. Used rarely. And also synttomycin is used locally. Lincosamides. Mechanism of action: irreversible inhibition of protein synthesis in the ribosomes of microorganisms. Type of action: bacteriostatic. There are two agents belonging to lincosamides: lincomycin and clindamycin. Spectrum of action includes gram-positive cocci, actinomyces, anaerobes, bacteroides and clostridia, gram-negative anaerobes, fusobacterium, for example. For treatment usage, we use lincosamides for treatment of abdominal cavity and small pelvis infections, gynecological, anaerobic infections, pneumonias, osteomyelitis, purulent meningitis. Toxicity is relatively low. Can cause allergic reactions, dyspeptic disorders, glossitis, stomatitis, phlebitis. Rifamycins or enzamycins include rifampicin, rifamycin, rifabutin, rifaletan, rifaximin. Maybe rifa, I don't know. Rifamycin, rifabutin. Mechanism of action: inhibition of RNA synthesis in microorganisms. Type of action: bacteriostatic, but in high doses bactericidal. But in high doses and toxicity is increased. The spectrum of action: gram-positive cocci, besides Mycobacterium tuberculosis, gram-negative Escherichia coli, Salmonella, Shigella. More often, these antibiotics used for treatment of tuberculosis, sometimes pneumonias, osteomyelitis, pyelonephritis. Toxicity is high. Side effects include allergic reactions, dyspeptic disorders, hepatotoxicity, leukopenia, coloring of the urine, sputum and tears red. Reversible, of course, reversible. You can read following information. The lecture is over, but these are examples of usage of antibiotics for preventive antibacterial therapy in surgical practice. Not for treatment, for prevention, before operation, for abdominal surgery, thoracic surgery, operative gynecology, and operative urology. And universal antibiotics. What does it mean, universal? They are active against aerobic and anaerobic, gram-positive and gram-negative. It means having widest spectrum of action. And they are resistant to majority of beta-lactamases. Such antibiotics are called universal. Universal antibiotics can be used for most of infections. Universal antibiotics include monoagents, cephalosporins of 4th and 5th generation, carbapenems, fluoroquinolones of 3rd generations, and combined drugs, semi-synthetic penicillins plus beta-lactamase inhibitors, cephalosporins plus beta-lactamase inhibitors, fluoroquinolones of the 1st and 2nd generation plus nitroimidazole derivative, and quinolactams. These are universal antibiotics. Goodbye.